Good morning, everybody. Welcome to High Rounds. I am going to introduce our speaker today, who is from my alma mater, where I did my medical school at the University of Mississippi. So Leandro Mena, he is a clinician, researcher, and public health advocate with expertise in the prevention and clinical management of STIs and HIV. He's the founding chair of the Department of Population Health Science at the University of Mississippi Medical Center, John D. Bauer School of Population Health. And he's also a professor of medicine in the Division of Infectious Diseases. Dr. Mena directs the Center for HIV/AIDS Research, Education, and Policy at the Merle Evers Williams Institute for Elimination of Health Disparities. And he serves as the STD medical director for the state of Mississippi. He's also the medical director of the 5 Points Clinic, which is Jackson, Mississippi's public STD clinic. And he is co-founded the Open Arms Healthcare Center, which is the first LGBTQ+ clinic in Mississippi. In recognition to his work for developing a model of the program for culturally competent HIV prevention and care for Black men who have sex with men, this model that he developed has been replicated in clinics around the country. Because of this, he was awarded the 2016 Achievement Award by the Gay and Lesbian Medical Association. He's board certified in infectious diseases and is a fellow of the IDSA. Dr. Mena's interests include understanding dynamics of HIV transmission in racial or ethnic, gender, and sexual minorities, as well as the development of and provision of culturally competent quality health services to these underserved populations. So Dr. Mena, I will hand it over to you and we can get started.
Thank you, Elliot, for the introduction. And thank you, for inviting me to speak here. And for you guys, thank you, for being here. So I'm gonna share with you, it's our experience. I would say Mississippi is an interesting place, and once you get to know it, it's a place where we have, a really great innovation, but very often, what we have, and the result of innovation is really, more the product of our ingenuity, right? And our, resistance, to let things, continue to be the way they are, and not necessarily, the result of a very careful, a plan. As very often, you sit down and you have an idea and you make a plan, you write a grant, and by the time, you get the funding, none of the environment, the infrastructure that you had, is anymore there. So you have to kind of very often, adapt very quickly and be able, to adapt very quickly. So again, this is title of presentation, not the same, all blue, stress of the efforts to improve PrEP uptake in Mississippi. So again, I'm gonna focus on some of the work that we are doing in Mississippi to really improve, access and persistence really in HIV prevention services. So these are my disclosures. And the objectives for the presentation today is I'm going to describe the main disparities in HIV epidemic in the US and Mississippi. And we're going to identify factors that affect scale up of PrEP in the South and Mississippi. We're going to describe examples of PrEP cascade in Jackson, Mississippi, and present data from evaluation of some of the novel models that we have in PrEP initiation in Mississippi. So before I move forward, if you guys have any questions, please, go ahead and ask them. You can mute, or, I don't know, Elliot, if anyone, put a question in the chat. I'm not able to see the chat. So if you can kind of read the question, I'll be happy to answer them along the way.
Yeah, I'll help monitor the chat.
Okay, thank you. So again, as you know, the 2018, the HIV epidemic in the United States, right, is centered in the South. More people are living in the South, with HIV, residing in the South than in any other region of the country. 42% of all individuals living with HIV live in the South, where only 38% of the population. And in 2018, 51% of all new HIV diagnoses in the US, happened in the South. So again, in terms of geography, the HIV epidemic is highly concentrated in the southern region, where a lot of this epidemic, different than in other parts of the country, really, have a center, in many rural areas that really lack, access, and transportation and many things that really make, HIV care much more difficult. So this slide really presents the number of diagnosed with HIV infection in 2018 among men versus men, who have, who again, as a group, are disproportionately affected by HIV. They only represent 2% of the US population, yet they are about 70% of all new HIV diagnoses. So in the South, not only the South had more diagnosis of HIV infection among MSM, but Black and Latino MSM really are disproportionately affected by HIV. And this, so it's no surprise, how the CDC, lifetime risk of HIV diagnosis by race really show these, tremendous disparities. The lifetime risk, for HIV infection among white MSM, 1 in 11, for Hispanic MSM, 1 in 5, for Black MSM, 1 in 2, and it's very difficult, for example, for providers. I'm sure, you guys have the same experience. When you sit down with a Black man who is men, and you try to explain them, that your risk of being HIV infected in your lifetime is the same as not, it's a flip of a coin. The risk is so large that people really don't understand that. For me, the way I talk to my patients, say, this means that unless you do something really, really very deliberate not to get HIV, the chance is you're going to end up with HIV at some point in your life. I mean, so although this is a possibility, really, it's a presented possibility that doesn't need to happen. I always like to show people this a chart that comes from a publication from 2013 that basically show that in some areas of our country, like South Carolina, what is a probability is actually and has been the reality for some years. In South Carolina, 50% of all Black MSM are living with HIV. In Mississippi, in 2013, 46% of all Black MSM living with HIV, 20% of all Latinos living with HIV. You see, there are 6-7 states in the South where over 30%, at least 1/3 of Black MSM are actually living with an HIV diagnosis. And so that projection, right, is real. And this study was done in Mississippi, at a time where it was estimated that about 40% of all men in Mississippi are living with HIV. And then the incidence rate among HIV negative men that year was actually 4%. We calculated, in a study where we enrolled 600 Black MSM in Jackson between 2012 2016, an HIV incidence in Black MSM who are 15 to 29 years old of 6.7%, per 12 months. So again, a very high HIV incidence. In the absence, of HIV prevention, it suggests, that in a decade or so, I think, HIV has the potential to be a problem primarily of the South. So just to give you a snapshot of Mississippi, our population, estimated, and corrected this in the other version, the population is actually estimated to be 2.967 million in 2020. And we actually lost a little bit of population, 0.038%. In general, one thing that is characteristic of Mississippi is that 55% of population reside in rural areas. This represents a geographic barrier to care, as many people living with HIV live far from the nearest treatment location. In Mississippi, about 51% of people living with HIV live in rural communities. We have the highest percentage of residents living in poverty, 19%, and the high rates of uninsured people living with HIV with 39% or Medicaid only 14%. The health department estimates that about 75% of patients who receive in their medication through the AIDS drug assistance program, that, as you know, is a payer or last resource, would have qualified for Medicaid should Medicaid would have expanded in Mississippi. We also have the highest rates of syphilis, gonorrhea, and chlamydia. Really fueling, as you know, our HIV epidemic. So in terms of HIV and AIDS in Mississippi, the rate of new HIV infections in Mississippi is 16 per 100,000 Mississippians. We have the 6th highest in the US, and this represents a 12% increase from 2017. Among people living with HIV in Mississippi, which is about 10,325, these are people living with a HIV diagnosis. 64% receive medical care at least once, and 44% were virally suppressed. So 80% of people diagnosed with HIV in Mississippi were Black men who assist with men. And 80% of the people diagnosed in Mississippi were Black MSM who were less than 25 years old, representing only less than 1% of the population of the state. And 37% of women diagnosed with HIV were diagnosed with AIDS within 1 year of the HIV diagnosis. Jackson, Mississippi is the city in the country among metropolitan statistical areas that has the highest rates of HIV diagnosis among Black women in the US. So, so in Mississippi, really geography is really important. And this was an analysis that we conducted with colleagues from Tufts University and Brown. We use spatial epidemiology and statistical modeling to identify and characterize HIV hotspots for the general population, for MSM and African Americans. So HIV clusters were concentrated in Jackson, and the Jackson is the green, is the green center that you see in the red blood in the center. But I always say that this hotspots for HIV in Mississippi are Jackson and the rural areas that surround Jackson that very often, are the place, the space where people live. So, I mean, but people come to Jackson, as the metropole. The risk space for many of these rural areas, continues to be Jackson because it's a place where people come to access health services, but people come also to socialize, and to hang out and to be able to and to be who they want to be. So interestingly, what we found is that HIV was positively associated with clusters where there were individuals of African American race and urban location, and paradoxically, those communities, we use census tract data where there were individuals with a higher proportion of individuals with less than a high school education or having higher percentage of population living below poverty. They were negatively associated with being in a cluster. So one of the ways that we can interpret that is that many of these individuals who live in these rural areas who are very impoverished with very low education are so vulnerable, to what they depend, from their family to their community, that they really can't afford, risk. So people basically in those communities really, the risk behavior is such that they're less likely to become HIV infected because they really have to be, they can't afford, people to find out, that they have sex with men. So progress, towards reducing new HIV infections really has stalled in recent years. And about the ending the HIV epidemic, where the goal is to decrease HIV diagnosis in the US by 75% in 5 years and by 90% in 10 years. So this is Mississippi's goals. In the past 5 years, I mean, we actually have only a 7% decrease in new HIV infections. So which means that we really have to make almost 10 times more progress. And I think the question is, I mean, do we do the progress by working 10 times harder, or we kind of think about in ways, more creative ways that really, that can make, the work that we need to do more effective to really reach the outcomes that we're trying to achieve. So, PrEP, of course, is really a revolutionary innovation, but implementation has been extremely difficult. And I think, regardless of the difficulties of implementing PrEP that we have in the South, I think that PrEP has not been the thing that many of us expect, right? That you say, well, there is PrEP here, and there's a line of people coming in, because, why not, right? We know that because the PrEP, is intended to reduce HIV acquisition rather than treat disease. PrEP-related outcomes differ from the HIV treatment continuum. And this is the PrEP continuum that was proposed by Amy Nunn and collaborators. That has, 3 different steps. The first 3 steps, focus on PrEP awareness. Step 4 to 7 are related to the PrEP uptake, and step 8 to 9 focus on the adherence and retention to PrEP. But I want to, to think about that each one of these little steps, right, represents, I think, an opportunity for many of these individuals who otherwise perceive themselves to be healthy, who very often, don't think that they are at risk. And that's why we tend to kind of talk, less about risk and about, indications, and how, taking this, can significantly reduce, the chance that you will get HIV. But it's really, an opportunity for people kind of to fall out of the continuum, right? And to turn around and go away without really the weight that you may have with HIV, that people somehow, understands that at some point, unless you get treatment, really bad things can happen. So the Southern AIDS Coalition really developed, an initial note of potential challenges to access for HIV prevention and care in the South. And I adapted, this one over the years have been modified, as we have learned new things, about the challenge to scale up, PrEP HIV prevention services in the South. The rurality, of the South, no doubt that really, there are large distances and shortage of PrEP providers. Have patients who, if you remember the map, anything outside of the green, Jackson, very easily is 30 minutes away, 1 hour away, 2 hours away, to be able to see a provider for pre-exposure prophylaxis. Race, there's an increased proportion of African Americans in the South, tremendous racial disparities in healthcare and healthcare access, and then the unfair criminal justice system that really has an impact in people's, ability to get health insurance. At any given time, you can take, a sample, Mississippi. Well, Mississippi, is the state that has the highest proportion of population incarcerated, and that is reflected, in our HIV care continuum. At any given time, you can take a random sample of individuals living HIV from the HIV reporting system for ERs, and what you're going to find that 10% of those individuals will be incarcerated. So incarceration, dealing with the judicial system, really affects, it has an impact of about 10% no-shows for clinical appointments. It has an impact of 10% retention, for research studies that we do in Jackson that include a large proportion of African Americans. So if you look at the population of patients that we serve, 25% of them have been both incarcerated and convicted, the same proportion, which means that if you're Black in Mississippi, chances are that if you're incarcerated, you were convicted, because that may be the only way that you can get out. But the impact of that conviction, right, for the rest of your life is so important, because you're going to be less likely to get a job that's going to offer you health insurance, that's going to offer you a decent pay, pretty much kind of perpetuating, poverty for you and for the people around you. There is, no doubt, poor health infrastructure. Much of this has really been evidenced by how COVID has differentially affected our communities, and certainly, communities that are disproportionately Black or disproportionately Latino. The poor IT infrastructure makes, telemedicine or telehealth that has, so much potential, right, to really be a tool that can help us eliminate, disparities. It can really improve access to service, but that, doesn't necessarily correlate to eliminating disparities. There is a distrust in the healthcare system. There is, of course, the inadequate, state and federal funding, lack of education, underestimation of personal risk factors. The anti-immigrant policies and health-related immigrant bills. We have had patients that, because of some of the anti-immigrant policies, decided that, or called us, they don't want to get PrEP. Even PrEP was free, because they felt that they were using, resources of the federal government that could negatively impact their ability to normalize their immigrant status in the U.S. And then, at the end, certainly the HIV stigma and the aggressive homophobia that we experience, in the South. So in addition to that, you have, in 2019, early 2020, we have this, a campaign that was actually targeted to a specific, cities in the U.S. with a high proportion, with a high prevalence of HIV, right? And although it was directed, towards people living with HIV, about Truvada for the use and treatment of HIV, the campaign has had a tremendous impact, in people taking PrEP. This, screenshot that you see here at the center was actually one that I took a picture from one that sent me a patient of mine telling me that he was going to stop PrEP because he was having bone pain. So again, we had a significant number of individuals that actually discontinued pre-exposure prophylaxis between The second part, 2019, early 2020, because of these, campaigns, talking about the negative effect, indiscriminate campaigns, talking about the negative effect of tenofovir disoprosyl fumarate in bone and kidney function. So again, although PrEP was approved by the FDA in 2012, this is a really incredible study, by Aaron Ziegler, that I'm sure all of you are familiar with, that basically look at HIV diagnosis in 2016, and they use a pharmacy database, and they look at the proportion of PrEP prescription by number of HIV diagnoses by state to have this PrEP to need ratio, right? To see, how much PrEP was being prescribed, where PrEP was needed the most based on HIV diagnosis rate. If you see in red, the lowest PrEP, to need ratio, right, are really along the way of the states that have the highest, HIV diagnosis, in the South being there. So not only that, but also they look at the proportion of PrEP providing clinicians per PrEP eligible MSA 2018, and no surprise again, the South has, the biggest shortage, of clinicians who can provide pre-exposure prophylaxis. And Mississippi, a little clinic, this is 2017, one clinic in the center of Jackson, Open Arms Healthcare Center, basically provides 75 to 80% of all the PrEP that is provided in the state, requiring, many people, if they have the means to basically come to Jackson to access pre-exposure prophylaxis. So again, there is a big disconnect between PrEP need and PrEP use. And I will say, and the need for, as we think about, our healthcare system has really, we're really designed, or we're never designed with the needs, or in mind, the populations that we very often try to engage in HIV prevention services. So for us in Jackson, one of the things that we have done that for us is I think in many ways, tremendous innovation really is what we call a structural intervention. Open Arms Healthcare Center is an example of that. It's a 100% community-driven clinic that came up with a space, that was, designed by the community, including, the name of the clinic was named by the community, by focus groups. We asked them, what kind of services do you want us to prioritize? And they said that they want the food pantry, mental health, HIV prevention. And that was before, food insecurity, was a thing. As a provider, I didn't think about food insecurity until some of the HIV medications that we were giving were requiring people to take it with food. So I started asking people, tell me about your meals to see if it made any sense, for me to use these medications. And then I realized about 20% of my patients didn't, miss meals because of lack of money, right? At least once a week. Again, no surprise for the community who, built this clinic actually next to a food pantry. And I didn't really immediately understand the connection until I started asking those questions. But the other thing that was really important, and it took me some time as a healthcare provider who always work in a hospital and clinic, is to understand that people really didn't want this clinic, to look like a place that you take care of poor people care of poor people. So the clinic has always looked, if you come in, like a living room of a house, where you're in a nice living room where people can sit and have a conversation, really taking away, a lot of the stigma, a lot of, I think a lot of trying to break down, the negative perceptions, that people have had, that many of these, Black people, gender, sexual minority individuals, have had when accessing health services. So again, Open Arms, is totally community driven, but it was open thanks to the collaboration and partnership with the academic center, the University of Mississippi, Division of Infectious Diseases, and the health department, who really, provide, support for some of the testing that was able to open the clinic. So the PrEP clinic in Jackson, looks very different than many PrEP clinics, in the sense that although we take 90%, male, 87% MSN, 70% of the PrEP patients are African Americans, and again, about 75% of all the PrEP patients in the clinic are younger than 34 years old. Tens of college, 59% have some college or higher. Low income, half the pay people, who comes to the clinic makes less than $12,000 a month. 50% are uninsured, and 25% of individuals are, in cellular disconnect relationships. How do we get patients? We have a referral network. We established a referral network, where the STD clinic will send, people. Some individuals were self-referred, or a friend, referred them. And then, the rest of the people came from either doctors who refer patients from us, community partners, people who came from PrEP programs, finishing PrEP, or from some of our research studies. But especially in the STD clinic, we couldn't understand. I actually served as medical director of the STD clinic, so I knew that we were referring a lot of people there, but people were not showing up. And when I talk to people, when I talk to consumers, we learned that people have two main concerns. People, at that time, we're talking about 2015, they had two concerns. They were concerned about the side effects, and they were concerned about how much PrEP was going to cost them. So I said, okay, let's do a program. Let's get, the first, 100 high-risk individuals, right? Young Black MSM, these were mean age 22.7. They were high risk, meeting CDC criteria, had STDs, anal sex, multiple partners. 66% of them, as you see here, were in non-exclusive sex partners, and more than half were uninsured. So we make sure that we took them right after the clinic, and we invited them to participate in this study, where we gave them, spend time, educating about what PrEP was. We have make sure that they understood about the side effects, addressing their concern. We make sure they understood how to get paid. And at the end of that, we ask them, do you want an appointment, for PrEP? And if they say yes, we help them to make the appointment. We remind them of the appointment. And as you can see here, from 108 individuals, 72% say that they're willing to start PrEP. At the end of the session, 71% scheduled the appointment. 20% actually show up for the appointment. 15% pick up their medication at a 3-month, only 9% attend the appointment. This group, 18 to 29 years old, is the same group. Was part. These were 108 people of a larger group of 468 individuals that were HIV negative that we followed for 12 months, right? And we were able to determine the 12-month HIV incidence was 6.8%. So 6.8%, this is a group that had an HIV incidence of 6.8%. And only, again, 9% of them were still, taking PrEP after we did everything we could do to make sure they were educated and they were facilitated, that PrEP appointment. So again, what we conclude, is like once people, leaves the clinic, there are factors, life takes over, and the factor that, and people have to prioritize things, and certainly, HIV prevention, for whatever reason, was not really among those priorities, or people couldn't afford, right, to prioritize that. So we say, okay, what else can we do? I said, let's integrate, what about if we integrate PrEP into partner services? Mississippi does not delegate partner services, and disease intervention specialists, have to, interview everyone who is diagnosed with HIV, then interview all their partners, get them for HIV testing, and they do the same thing with syphilis. Nowadays, for the past 3 or 4 years, they really are not doing that. They do that with some gonorrhea cases, and certainly, not with chlamydia. So during this period, evaluation period between 2017, October, and December 2018, there were 185 individuals in the Jackson metro area that were assessed for PrEP, out of which 58% were PrEP eligible. From those, all of them were offered PrEP. And from those, only 26% accepted the PrEP, and from that group, only 39%, which means 11 individuals, actually attend the first PrEP appointment. So again, only 10% of people, who were assessed for PrEP, were PrEP eligible eventually, showing up for a PrEP appointment. And that PrEP appointment happened 3 to 4 weeks, after the individual first accepted PrEP. So there was a delay of 3 to 4 weeks. So again, in terms of takeaway messages, right? In theory, this was a really good idea because, disease intervention specialists meet with high-risk individuals, but it kind of missed the mark. And we really need programs. We realized that we need a program to do a better job of promoting PrEP and reducing the time from being offered PrEP to starting PrEP right away. So we felt that in this model, there was a limited knowledge about PrEP. by the disease intervention specialist, including the health benefits, the availability, the cost. I mean, we felt that patients have questions that they really couldn't answer. And that was true for the clinic staff. The long delay between referral and appointment may result in low appointment attendance. And then at the end, there was a very small proportion of those individuals with PrEP indication who attended the PrEP initiation appointment. So, around that time, one of the things we started doing is that there were some videos about explaining what PrEP was, right? So I said, okay, let me have, I send the link to the nurses and to the DIS and to, staff that were in the clinic, the phlebotomy, said, why don't you, when the person is sitting down here waiting for the HIV test, the rapid test, why don't you play this, on your phone and show it to them about what PrEP is, or send them the link and ask them to share the link with friends. And that idea, actually, I shared with, that we were doing that, I shared with colleagues from Brown University with Dr. Larry Brown and Laura Whiteley. And we decided, well, that's a really good idea. So how about if we kind of try to find some content, and test, if sending people links, with this content that is already available out there, that is free, we can develop this intervention and see what happens. So that's how, this intervention came up. It's called PrEP Mobile. And PrEP Mobile is an intervention that we developed and tested in Jackson, Mississippi to improve PrEP uptake among young Black MSM. The intervention was guided by the IMB model. We targeted social support, stigma, and communication with providers. This intervention was really, composed of free, publicly available links, to interactive websites and YouTube videos that provide factual information and motivational material about PrEP. So the intervention materials was chosen based on the barriers and facilitators elicited in focus groups with young Black MSM, and it was texted to men enrolled in the study over 4 weeks period. They got 2 links every week for 4 weeks. So for a total of 8 links. We found that Black men who were 21 years old or older, who received the PrEP health intervention, were significantly more likely to be taking PrEP at 12 weeks after the intervention. These men were also significantly more likely to have picked up a PrEP prescription by pharmacy records over 24 weeks period. And the intervention was also associated with an improvement in knowledge about PrEP and a decrease in internalized hormone negativity. So again, the other thing that we noticed, I mean, in Open Arms, when we started a PrEP program, as opposed to the health department, people get tested for HIV and we offer PrEP right away. So in Open Arms, 85% of people who have PrEP indications and we offer them PrEP, almost 85 to 90% of people, we start PrEP on the same day. So I said, well, what about, I mean, most clinics here in Jackson, they actually, that do HIV testing, they don't have the capacity to start PrEP right away. So I said, what if, if we could start PrEP right away? I mean, the problem is that we will not be able to know the creatinine, of the person, of the Hep B, surface antigen status, or the chronic hepatitis status. But by then we had started PrEP already in over 350 individuals. I went back to the database and I looked at how many people, had an abnormal creatinine that we did not suspect that could be abnormal based on the clinical history, either history of diabetes or the age above, 45, or some other, hypertension, something else, that suggested that the renal function would have been abnormal. It was 0. I mean, I said, well, how about if we, go ahead and talk to people on the basis of the HIV negative test and the indication and the medical history, and in the absence of signs and symptoms of HIV infection, let's go ahead and start them on PrEP and let's do the linkage after. Let's see what happens. So again, this rapid PrEP study project was funded thanks to a grant from the CFAR, University of Washington. So the objective was to develop an optimized, rapid PrEP initiation model to evaluate the acceptability and effectiveness of the rapid PrEP model and to identify barriers and facilitators for implementation of the model. So in the STD Clean, we have the standard, STD HIV screening and risk assessment, the standard partner services, and rapid HIV tests. If the person was HIV negative, then it was referred to a PrEP navigator who did the education, assessed for acute HIV infection, obtained medical medication history, did insurance paperwork, assessed if people had insurance or not. If they had insurance, if they didn't have insurance, we enrolled them in the patient assistance program, and then provide a prescription for PrEP on the same day to a local pharmacy. Then within 12 weeks, we set up an appointment for the individual to come for the creatinine and the Hep B screening to complete all the testing. So what's different about this program is that we were lucky to actually have a pharmacist working with us. So the navigator was a clinical pharmacist. And then, we provide prescription, again, as I say, the same day as the referral in the absence of a clinician. This interaction happened sometimes in person. If the person was willing to come to see the pharmacist in her office, it happened over the phone or it happened via telehealth. And we did that without completing the baseline creatinine and Hep B for initiation. For women, a pregnancy test was done in the clinic where the HIV test was done before prescribing PrEP. So this experience is actually reporting AIDS patient care, STDs, if you want to look more about it. But overall, we had 121 individuals between November 18 and December 2019. The median age was 26. 62% were male. And this is what you see, when you adopt, similar to, I think, rapid initiation of ART, that basically you have a protocol where everyone who meets certain criteria is eligible. You remove the bias of the provider, and suddenly, most of our PrEP program typically, are going to emphasize PrEP in men. This program identified people who are at risk regardless of who they were. And about 38% of the people who came, who access, this rapid PrEP program were actually, women, high risk heterosexual, women who could benefit from PrEP. We have about 5%, 6 individuals who identify as transgender, 70% were Black, 90% were white, 3% Hispanics. 30% were referred by our disease intervention specialists because they either had contact to gonorrhea, chlamydia, or contact to syphilis or HIV. And again, 33% of individuals were insured. So how we pay for PrEP, 75% of people got Gilead Patient Assistance Program. And the reason for this, between who had insurance and who didn't, was either because the insurance that they had was through the ACA and wasn't one of those tiered insurances that doesn't cover for outpatient medication, or because these were individuals who were younger than 26 on their parents' insurance that absolutely did not want their parents to know about this. Otherwise, they wouldn't have had PrEP. So we actually, called Gilead, had agreement with them where they basically approved, the patient assistance program, if the patient was not the primary insurance holder. So people, 74% of people prefer to pick up in the pharmacy. When we offer people, the choice, the mailing, the medication choice, because we felt was more convenient. A lot of people doesn't want things, mailed to their home because the neighbors will take it, or, they don't want it that way. And we offer where do they want their follow-up appointment to be, more than half, chose the academic medical center, the office that we have. And then second best choice was the community LGBT clinic, but some people prefer other clinics. So how did PrEP continue to look from the 121 people who were referred to the navigator? 96% received the PrEP prescription. For the 68% actually filled the prescription, and 60% actually show up for the appointment. So again, overall, we went from 10% to 43% people showing up for the appointment, which I think was a little bit of an improvement. If people didn't fill the prescription, the pharmacist after 2 weeks canceled the prescription. I kept calling them every 2 weeks to see if they wanted to come back. After 3 months, what we did is that we just told them, hey, just keep coming to get tested for STDs and HIV, and we'll talk about it whenever you come back. So what we did, everyone, again, who made indication was referred to the navigator, and the navigator spoke with them within 2 business days of the HIV rapid test. 96% received, a prescription within 5 days. 72% filled the prescription within 7 days, and 51% of people attended the appointment within 8 weeks. Remember that we have the window 6 to 8 weeks, but a lot of people, and right now where we are is that almost 70% of people are attending the appointment within 7 days. So among the people who didn't show up for the appointment, 25%, no longer wanted to take PrEP, 10% lack of transportation, 6% forgot about it, 10% never started PrEP, 70% other reasons, 31% were lost to follow up. So 1 out of 4 of the 39 clients who did not pick up their prescription, later on, contacted the navigator to reinitiate the process. Again, suggesting that if we give time to people, they will, some of them will turn around and they want PrEP. So again, this is overall acceptability, as you can see, the program was generally, very well accepted by people, but about 10% of people really say that they prefer to talk to a doctor or a nurse. So overall, patients were very comfortable about not feeling judged or embarrassed. Candice was the pharmacist that we had, and they said that she made them feel very, welcome and comfortable throughout the process. They feel like the ease, of the information that the program provided, and that they felt that they're making, a way for people to stay HIV free and be able to take medication without insurance. So advantages of having a navigator, that was a pharmacist is certainly, I think pharmacists are expert in navigation and they really know the ins and outs of insurance and health service navigation and pharmacy benefits, paying and patient assistance programs. And for us, in Mississippi, a collaborative agreement allows pharmacists to prescribe, directly, using the physician without the physician being present. But they're difficult to support. In summary, again, our program was able to fill, prescription. 85% of the people that we fill the prescription within 1 week of meeting the navigator, 2/3 attended the appointment, and we found that this model was acceptable to patients. So in terms of barriers, I think integrating the model with partner services, takes time, and still today we having struggle. Again, COVID, took away a lot of the disease innovation specialists, so we really haven't fully integrated, the program with them. There was some confusion with pharmacists and clinic. We recruit people in clinics that offer free STD testing. When we try to link people to a system where people has to pay, there was a little bit of confusion about how do we manage these patients. And certainly, even when people don't have to pay, but even when you have a process by which you assess people's ability to pay, that sometimes can be a deterrent and sometimes can be, the source of a stigma. People don't say that they don't have the $25, right? They say, oh, I'll be back. I'll bring it back, and then they disappear. They don't ever come back. So there were some client level barriers that may be addressable, like transportation, but many people still were lost to follow up. And we felt that integrating into, again, health department partner services required a dedicated staff. People, may not be ready to start PrEP, even if they fill a prescription. Pharmacists, are key in sustainability, but sustainability of pharmacy is questionable, in the sense, that it's very difficult to afford. And as a matter of fact, the way that we are running the program now is actually a nurse-led program without a pharmacist. Clients, no doubt appreciate, the non-judgmental approach. And people, again, will reconnect when they're ready to start PrEP. We just need to facilitate that reconnection. What we do in our clinic is that when people, comes, regardless of whether they're interested in PrEP or not, we actually, instead of telling people come back in 3 months, we give them appointments every 3 months to get tested for STIs and HIV. And we, for heterosexual, we do it every 6 months, but we call them and remind them for the appointment. So the question was, can we, this model be implemented in other settings? We felt that it can work really well in low PrEP providers capacity areas, as you see in most of our state. But we need a strong clinical partnership for the program oversight and to accept patients who have already started PrEP. We also felt that we need a dedicated staff for ongoing check-ins and follow-ups. And we obtained a grant from the HRSA, from UMC has a HRSA funded Center for Telehealth to be able to adapt some aspects of this program, via telehealth. So what we do is that we again work with healthcare or public health professionals to do their standard STI, HIV testing and assessment of HIV risk. And for anyone that they saw who either was interested in learning more about PrEP, if people want to learn about PrEP, we'll do the education. If they're interested in PrEP, we'll start them on PrEP. And these are the indications for PrEP. I mean, we were very, I think, flexible. Say, if you're MSM between 18 to 28, we don't need to know risk factors. I mean, we start you on PrEP. If you have you have more than one sex partner in the last month, or you have condom receptive anal sex in the past 6 months, we start your PrEP. Anyone with an HIV positive partner, or then anyone with a syphilis in the past 12 months, will start you on PrEP immediately. Then, so you can call our PrEP line, a pharmacist, as a matter of fact, a nurse now, or the insurance benefit navigator will give you the PrEP education. They will assess for acute HIV infection. They will, and indications for PrEP, of course. They will do the medical and medication assessment, assess for insurance benefit, prescribe PrEP if needed, prescriptions can only be done by the nurse. So the patient navigator can do everything, but the moment of prescription, they have to talk to the nurse, but the nurse can call the nurse of the physician. And then they schedule the telehealth visit with a provider. So we will refer the patient for additional laboratory, either to a laboratory of their choice if they have insurance, or to a health department clinic where they will get the creatinine, the Hep B, and additional STI testing. When the labs come to UMC, the telehealth appointment will be done with an MD or MP, and then subsequently, every 12 weeks, for a PrEP follow-up. So that's pretty much, how it works. So we started that program in February, March 2000. It was around the beginning of the COVID pandemic. So we had so far 151 individuals, clients that were seen by PrEP Navigator, out of which 95%, receive a PrEP prescription, out of which 94%, pick up their prescription. So I think, that's pretty good. The median age is 28, 80% are male, 20% are female. We have 2.7, transgender identified individuals, 73% are Black, majority are Black. And again, the majority, or a little bit over half, are uninsured. From everyone who got a PrEP prescription, about 72% have had an initial clinic evaluation, and 18% have attended a follow-up evaluation. So that follow-up evaluation is actually with a clinician. That means, we decided that a healthy individual, otherwise probably only need to see a clinician once a year. And if someone is available, the person is interested, we can arrange additional visits. But other than that, people get, the quarterly, laboratory test. They get reviewed by the nurse, and if everything is okay, the prescription gets refilled without seeing a clinician. We have about 41 individuals who have not had an initial clinical appointment, and it may be because they are within the 12 weeks kind of a window where that appointment is being, coordinated. So again, what's next? Next steps. We're actually going back to our initial rapid initiation, and we are looking at 12-month follow-up data, because we want to see what happened with people who initiated, 12 months later. We're actually, doing qualitative work, interviewing individuals who didn't pick up their prescription, people who pick up the prescription but did not take it, people who took the PrEP but did not attend the appointment, and people who attended the appointment but discontinued PrEP. So this is something that we're doing this summer as part of a R21 that we got from the NIH to be able to look at this thing. So we are working right now on expanding UPrEP Mississippi to community-based organizations in Mississippi, to health department clinics and other rural clinics, because we really think, that this is, again, what we want to do is not necessarily to replace what's actually needed, which is, the development of culturally competent providers, in a geographically diverse, in diverse areas in Mississippi where people really have access, but we want to make sure that this program, UPrEP Mississippi, is really a safety net. It's a net that really, keeps, that can be able to catch, everyone for whom whatever may be available may not be, good enough. Because again, it's not only providing access, but it's really, having access that people is willing to use, right? And again, because of the homophobia, because of the stigma, even when you have a rural clinic, right? That rural clinic that may be closest to you, may not be the clinic where you want to go, where people wants to go because of a number of reasons. So I want to end, by acknowledging the support and the collaboration of so many, individuals and organizations. And again, this represents, a really a small, number of people and institutions that have collaborated with us, over the years in help us, supporting us in developing many of the programs that we have implemented or implemented in Mississippi to really try to rethink the way, we deliver services, HIV prevention services, to our patients in a way that that we hope, is more responsive and attentive, of what people, expectations and preferences are. So that's all I have to say, and I look forward to your questions.
So there are a couple questions, Dr. Mena, in the chat, and so I'll help kind of go through that. The first question I saw is someone's asking, how effective and active is Ryan White Council and the Prevention Planning Committee in Mississippi?
Um, it's, let me start by how active. They meet, I think, they meet once a month. Um, and, uh, and to be honest with you, the Ryan White Planning Council is not very, I never feel that they're very effective in guiding, strategies. The health department, they meet and they talk, and very rarely, things evolve into strategies, that have an impact.
Okay. And then someone else is asking about re-engagement of patients that were lost to follow-up. And have you been able to interview any of these people that were lost to follow-up and find out reasons why?
So for this particular program, for the rapid PrEP program, we have not. That's something that we're doing this summer. But I have other studies. Since we started digging in PrEP, we were paying attention, to that because we wanted to learn what happened. And of course, we have, for example, a study that I'm doing with colleagues from Brown University, Emmy Non and Phil Chan. And it's a study that follows, people who start PrEP in Rhode Island, Jackson, and St. Louis. It's called PrEP Cascade. We basically, enroll people and follow them for 18 months to see what happens. Of course, there's a little bit of a bias, right? Because we can only get the people who tell us, that they stop taking PrEP. The people who actually drops, we don't. But what we learned is that a lot of people, stop because they don't feel they need PrEP anymore. They are in relationships. Some they say they're not planning to have sex anymore. So yeah, very often people don't want to continue taking, they don't want to continue taking PrEP. What we find out by looking at pharmacy data, right? And by looking is that, although people are supposed to take daily PrEP, almost everyone takes some form of intermittent PrEP. I mean, during any given time, any given month, I think 60% of people, didn't take PrEP, for at least 7 days. So people have really, have this, not necessarily event-driven, but intermittent PrEP. And we start trying to understand better what drives that, and whether, this is something that makes sense, or people is doing that, without recognizing, right, the potential risk of becoming infected with HIV.
A few people have been messaging me privately. I could ask you about 40 questions, but I'm gonna see if, so Susan Little, I don't know if you want to unmute. You asked one question, but I know this is something that you and Gabe have been working on. The question is, what is the loss to follow-up rate among people who have completed more than 12 weeks of follow-up? I don't know if you have that data.
I don't have that data, but I can tell you, for example, that, I show that 45% of people had insurance, and about 25% of people, were in serious discontent relationship. So at 12 months, if I look at people who have been there at 12 months, 75% of people are insured, who do 12 months, and 50% of them are serious discontent relationships. The way I interpret that is that, considering, right, the access to PrEP, including medication, is pretty much free. It doesn't really matter if you have insurance or not. We get it to you, right? And as a matter of fact, if you have insurance, it's a little bit more complicated because you have the co-pays and you have to this, you have that. But I think that the same social determinants, right, that determine whether you're gonna have insurance or not, right, are gonna be operating, keeping you in PrEP or not, right? And the balance is how much this is gonna cost me. What is the work I have to put in, and what is the benefit? And I think that when you have a partner who is HIV positive, the risk is real. That concept, the abstract concept that you may find, you have the potential of becoming HIV infected, but having sex with people who are HIV infected is no longer, an abstract concept, and that makes, so I think that in general, the people who are likely to be persistent in PrEP in our setting among largely Black MSM are people who are insured, right? And you can make your deduction who are those individuals, and people who have a better, who acknowledge, right, the HIV risk, and I think that what better way than having, a service called a partner.
I have a quick follow-up question, and then I'm going to let maybe Dr. Wagner have the last question. You talked about, the Gilead Assistance Program. We use that too, but Gilead Assistance, unless you're talking about it in a different way, only covers the medication. We in California are very lucky. We have the PrEP Assistance Program, which for uninsured or underinsured patients cover the lab costs, the STI treatment, all of those things. What is the coverage in Mississippi for those individuals, so that they can attend their clinic visits, get labs done, STI testing and treatment?
Over time, we've been doing, whatever we can, right? So for example, when I started first PrEP clinic in Mississippi, the health department agreed to pay for the HIV, the STDs, testing. So I said, well, 85% of the Hep B, the population younger than 30 years old has been vaccinated for Hep B. So we actually called the health department, got access to their registry. And before we order Hep B screening, we look at immunization status. People were immunized, we didn't do it. So that saved us $26.
Yeah,
so
wow.
I called the health department public health lab, and they agreed to do the creatinine for $2.25 for us. So then we used the STD grant to get a 340B pricing, right?
Right.
With 340B income, we were able to pay for the cost, of the cost that we had there. So that's open arms. So I opened another clinic, at the University Express Clinic, where basically I use the income that I get from research, the clinical research studies and clinical trials to be able to pay for the creatinine, which I do. Again, it costs me almost nothing. So we make sure, again, that the cost of PrEP has no cost to the patient.
Okay.
We have done surveys, of people asking them, people who are HIV negative, how much can you afford, right? And what you find that most of them can afford zero. I mean, for even, and even for people who are insured that may have a copay, I mean, SIP insurance, is horrible. It's the 80-20. For example, my insurance have a deductible at the beginning of the year, $2,000. So the first $2,000 I have to pay. Who can afford that? So even if you have insurance, I mean, we found, for example, that a $40 out-of-pocket cost is the point, the people turn around.
Right.
But for Black MSM, we asked them, how much can you afford? And that number is zero. I mean, if you don't do this for free, people will not, I mean, we will never get where we want to go.
Yeah.
We will never be able to address the disparities.
Thank you. Dr. Wagner. Oh, there you are. Good.
Hi, Dr. Mena. Thank you. So we here in San Diego have also done our immediate PrEP initiation program, and we hope to publish those results soon. And so, yes, I read your study with interest. And, in our experience, we have also observed a similar drop at each step of the PrEP initiation cascade. And our population here is distinct. It's not predominantly Black MSM, it's predominantly white MSM and Hispanic. And interestingly for us, we observed a steep drop in the number who presented to our community-based NIH-funded sexual health clinic, and those who expressed interest in starting it right away. So there was a significant drop there, 38.4% of participants. And then the rest of the initiation cascade went down from there. It looked a little bit similar to the experience. We had over 2,000 people in a 15-month period analyzed. So it was obvious that, PrEP availability alone was not, as I'm sure you may have observed, a facilitator to PrEP initiation. And there's probably population, environmental, and individual factors that play at the decision making of actually, yes, I want to start today. So that was just a comment. My question was, I'm also interested in telehealth for PrEP initiation. And here we, of course, we're the border city of Tijuana. We have a predominantly Mexican American population, and I'm interested in bilingual telehealth visits. One question I had is how is the STI testing being done through the telehealth program? Are they getting self-swabbed somewhere or are they going to like a commercial lab for self-swabbing or?
So yeah, so that's a great question. So I think it's almost like it's a hierarchy, right? Of priorities. I mean, and the priority, I think that PrEP is a great opportunity to really, bring, individuals who are affected by many health disparities to healthcare. And the destination is not keeping someone HIV negative, it's making sure they have better health, right? Along with a more holistic approach to health. But at the beginning, the urgency, at least for this population, Latinos, Black MSM, white MSM, for whom the HIV, the risk of HIV is so high, is protected for HIV so you can do the rest. I mean, and although the guidelines say that, yes, you have to do STDs and all that stuff, I mean, we know that PrEP can protect people even if they have STIs, right? So the first thing is that I want to get them on PrEP, and the only thing that I ask is the HIV testing. So for everything else, I have time. So I will work with the individual and say, okay, what do you, where you are located, can you come to one of our clinics? If that's not possible, we have an agreement with the health department that we can, Mississippi has, 82 counties with 100 something, county clinics, most of which are closed most days of the week. I mean, so we have to work with the health department and find out, is there a clinic that is open where they can go in? And the health department has agreed to do the creatinine for us for free. They do the gonorrhea and chlamydia screening and syphilis. And again, with the Hep B, I will just, wait until they can come. So we got a small grant from HRSA where we actually can, using molecular lab, send people a kit home so they can collect their own specimens. And I actually have 2 different studies that are testing that in rural areas. What I can tell you, for example, is that, again, great innovation, but all that innovation, I think that can potentially increase access, right? Can also result in bigger disparities. What we have seen, we have a study that is reaching out, rural MSM in Georgia, North Carolina, Alabama, and Mississippi. And what you see is that most of the people that we enroll for young MSM up to 29 are white, right? So the thing is that you have to imagine, so, okay, where, Black MSM live in rural areas, right? In Mississippi, Alabama, Georgia. And they probably live at home, with very little privacy, and we're very, without the means, right, to go to the gas station, to an Amazon box, so they can deliver the box, without people, or something delivered home, and people say, what is that for? Why are you doing that? So that's what we're doing. We have, so what we try to do is to give people access. We tell people, give people choices. We tell people we can either send you a box home, or whatever you want us to send it, or you can come to a local clinic. For example, we have this collaboration with the health department so people can go to a local clinic. So to make things easier for people. So I had a patient, one of my first patients, who is from Greenville, actually wanted to go to the clinic in Greenwood, right? Because he didn't want to go to the clinic of his town. So you think that you're addressing the issue of transportation and bringing things closer, and there's a different, they have their own pride. Yeah, I think that at the end we really have to think about creating this menu of options, to people. I think that when it comes to STI screening, I always say, you think about Red Box, right? The thing where you get the videos. Can we have, something in a Walmart where you can, get a box, go to the bathroom, get tested, drop it. It gets collected once a week for the STI testing, and then depending on the results, you can come back with a code and get your medication, like a doxycycline or azithromycin or cefixime, or some new drug that will be effective against, GC that is non-pharyngeal. So that's the kind of things that I think, are going to help, in rural areas, because again, it's not like rural areas don't have clinics, they have rural clinics. But the question is, given the stigma and the homophobia, are the people who are the highest risk of HIV really going to use those clinics? Or what will it take? so they can do it.
Dr. Mena, thank you so much. I'm looking at the time, it's 7 after, and a few of us have to hop over to another call, but I could be biased. I think this is the best talk we've had all year. No offense to anyone else. No, I'm just kidding. This was so helpful. The data is really interesting, and you've obviously put so much work into this, trying to improve, healthcare for the people in your community. And I think a lot of us are just in awe now. I know I am. So thank you so much for what you do. Thank you for sharing it with us. I think there'll be probably some emails and calls to you after this for some help and support, maybe collaboration.
Well, thank you so much for having me. It's been a great pleasure.
Thank you so much.
I always say it's a privilege, to have the opportunity to work here in Mississippi. It's a true privilege.
Yeah.
Thank
All
you.
right.
All
Well,
right.
thank you. And thanks everyone else. Have a good day and afternoon.
All right.
Bye.